Billing OB/GYN ultrasound procedures. Legal disclaimer we put at the beginning of all of our presentations. This information is for general and educational use only. Content is not intended to substitute for professional, legal, or clinical advice. We strive to keep our information as accurate and timely as possible, but make no promises and guarantees it works for your local unique situation. At the end of this session, participants will be able to verbalize the basics of billing and coding in regards to ultrasound services. The participants will be able to verbalize the process of insurance claims and how it's similar and different for ultrasound procedures. They'll be able to verbalize the common medically indicated reasons that a healthcare practitioner would implement an ultrasound service and a higher probability of insurance reimbursement for that procedure. The participants will be able to verbalize the accuracy of documentation, the guidelines, the standards, the advocacy resources that are available to help get reimbursed by insurance companies for these ultrasound procedures. So let's start at the basics. People don't realize that billing insurance companies, you have to know a lot of things. You have to know all their insurance plans, their primary, secondary, tertiary, information about them, the date of service, the place of service, the procedure code, the diagnosis code, verification of benefits. Is there prior authorization needed? Is there a medical necessity documentation? Is there a referral? There's a lot of layers that people don't realize with billing insurance companies, and every year it gets more and more complicated. So that's why I strongly encourage with our consulting services and our resources we provide that I strongly recommend you get the best of the best biller either in-house or you outsource to an excellent billing company. The intention of this presentation is to help with healthcare practitioners so they're getting the right documentation, they're getting the right coding and medical necessity guidelines to implement the charges that the biller can do on their behalf. The pertinent demographics, the primary insurance holder, the date of the services, the rendering provider, the supervising provider, the supporting documents, the procedure codes, the diagnosis code, these things are all essential on every single healthcare claim. If you're doing a picture of a baby for fun and there's no medical indication, it's not going to be covered by insurance. You can always do a cash boutique service, but we're talking about insurance, reimbursement, medical necessity, and every payer makes their own rules. So government plans, TRICARE, Medicaid, Medicare makes their own rules and regulations typically based on CMS guidelines. Third-party payers, Blue Cross Blue Shield, Blue Care Network, Aetna, UMR, sometimes will follow the CMS guidelines and sometimes they'll make their own rules. And don't just assume because you know Blue Cross Blue Shield, every Blue Cross Blue Shield in every state, every union, every subset company also makes its own rules. So this is a sample of the CMS 1500 claim form in the paper version. Most people have electronic and a clearinghouse that it goes through, but it's good for everybody just to see the basics of what is actually put on an insurance claim form. And then here is one of a sample that's actually been completed. There's different levels to ultrasound exams. There's simple point of care, there's diagnostic, there's very formal high risk maternal fetal medicine procedures, Doppler flow scans, very technical. And so you need to be able to understand as a healthcare practitioner point of care what type of ultrasound exam you're doing, the lowest level. It doesn't matter so much the equipment, whether you have a handheld equipment, you're bringing it to someone at their office, home, triage versus you have a cart. That doesn't matter so much with the billing. It's the procedure codes, it's the documentation, it's the medical necessity. Why did you do the ultrasound? It's more breaking down of what data you're collecting and why you're collecting that. There's different things to think about with a standard obstetrical ultrasound exam, particularly done with a 20-week anatomy scanned by a physician. You're evaluating details of the anatomical structure, gross anomalies, but then there's also point of care, limited focused ones where you're getting pieces and parts. You're getting just the fluid level, you're just getting the heartbeat, placenta location, the growth of the baby, the cervical length. You're getting components. The limited obstetrical scan is more point of care ultrasound with advanced care practitioners, you want to follow up on management and assess a pertinent concern or question that you need more information on versus just a routine 20-week anatomy scan that radiologists, sonographers, physicians will be performing. Then there's also specialized obstetrical ultrasound exams. Those have to do with very detailed, high risk, MFM, specific history conditions, genetic things, chromosomal abnormalities. There's significant gross anomalies that have been found, and you want to follow up on those in details. That's use. Place of service is important because you want to do the accuracy of where it's being done. If you're doing it in the clinic, the office setting, most of the time that's what it's going to be. It's interesting with the home setting because sometimes it can be qualified as an office if it's a routine location and a routine ambulatory. If you have homebound patients, you have a limited someone on bed rest hospital setting and you're doing it in certain locations, you have to designate the place of service. These are the more common ones you'll see. There are getting more and more mobile CT scans, ultrasound services for rural clinics, rural offices where they bring the equipment out to them and do it. But most of the time, people are going to be an office, home, or birth center setting, inpatient setting, outpatient radiologist. Our stuff is more point of care. So 76812 specifically is a detailed anatomical exam from the transabdominal position for each additional baby. So if you have twins and you're doing that anatomy scan. 76815 has to do with limited. This is the one that most advanced practitioners are going to be using. You did a focus point. You wanted to know about placenta location. Is it low lying because there's vaginal bleeding, the heartbeat, the viability, position, growth, fluid level, BPP, and you would be using that code most of the time. And then 76816 has to do with more of a reevaluation. You already had a growth ultrasound and now you needed to follow up. The anatomy scan, not able to see the heart valves, now you're following up. So there are different contingencies of what you use and how you use it. In transabdominal approach versus transvaginal approach does have a different coding and charting system. So 76817 has to do with real-time images on transvaginal versus transabdominal. So it's really important that you denote and you segregate with your coding, your charting system, which codes you're going to use, how you're going to use them, what are your policies, protocols within your organization, so that you're making sure you're getting the right calibrations, you're getting the right images to have for the records of future use, the documentation. If you ever get audited by the insurance companies, that the procedure code reflects exactly what the care was given, the medical indication, the management, the thought process behind why that ultrasound procedure. So these are just more in details of what we just talked about before, procedure codes. You may have different specialties, different services, different region, or insurance companies make hybrid customized codes for unique situations, but these are just the more typical ones based on CMS guidelines and the standard national procedure. So you want to make sure that you're looking for a biophysical profile, non-stress test, without non-stress test, the Doppler studies, any of these things that you're doing, you want to make sure you're picking the correct procedure code that is specific enough for your needs and making sure if you're doing a Doppler study, you have the correct diagnosis. Was the fluid level high? Was it low? Is there an issue with placenta insufficiency, growth restrictions? Why are you doing the Doppler? 76821 tends to be more of MFM, higher level OBs, unique situations like with the porovirus B19 infection, doing a middle cerebral artery. Echocardiograms, definitely more high risk, 76825, but you should know about these following up studies. Doppler echo is traditionally not done by advanced practice clinicians. It's usually physicians and a high risk MF know these codes, especially if you're a biller taking this presentation. CPT code modifiers are really important. If you're doing an office visit and then you evaluate something at the bedside, you need a modifier, particularly modifier 25, to show it's a separate identifiable procedure being done. Because many of the payers, if you're listing a bunch of codes, they'll say you can't combine it. Those aren't billable charges. They're merged. When you did the evaluation for that office visit, we included the ultrasound. You have to show in your documentation, you have to show above and beyond with your coding and your language on your claims to reflect the care and the rationale behind it. If you did not perform multiple services, you do not have a professional component, you do not have a technical component like maybe the machine and the professional diagnosis. There's different modifiers based on your local payer mixes, the indications. I don't expect the average clinician to know all these nitty-gritty details, but just being aware, sometimes things get denied because of not having the most appropriate modifier or not even putting a modifier on there when you have multiple charges on one data service, triage visit that could be. These are the more common diagnosis codes used during pregnancy to indicate the medical necessity of why you're doing your ultrasound, particularly for genetic testing, dating issues, the growth restrictions. Maybe there's an autoimmune condition, there is a gross anomaly that you're following up on. The genetic testing came back late, history of preterm labor, evaluating the cervical length, unknown last menstrual period, those kind. You want to make sure that you rank the primary diagnosis and every supporting diagnosis on the charting system and on the claims, because every single thing you're defending, why did I bill that? Why did I do that procedure? It's really, really important to have that and maintain it in the records. All the images you're taking, save screenshots, put labels all over your images to help defend. That's the third-party payer policies are going to be completely different depending on your specialty, your region, the regulations change, the guidelines change. I'm going to see more and more requirements by insurance companies. Right now, they're traditionally paying for these limited point-of-care ultrasounds based on medical conditions, but I do see the trends shifting to requiring ARDMS certifications, requiring certain levels of competencies, quality measures, benchmarks to actually say that practitioner can bill for that charge. So that's why we're trying to push these educations, these competencies, getting more and more people ultrasound certified, because there's going to be eventually a point where the insurance companies are going to require it to get reimbursed. You want to archive all the images, make sure you got the correct date, the facility, the time, labeling everything, orientations. You may directly put it in your chart. It may be a separate scanned thing, just depending on how your system is integrated. You may have specific worksheets and flows and expectations that your organization puts. You need to make sure that the reports and the documentation are all signed, reviewed, you've got the proper chain of command, the scope of work, the referrals, the management plan, everything is written clearly so that if there is a question of charges and care that's being billed, any complications, any biometrics measurements, there's certain things required for certain procedure codes that you have to document in order to bill for them, and just for protecting your license, any gross anomalies. If something wasn't visible, it wasn't visible. That happens commonly with GYN, ovaries. Certain things are just not able to visualize at that time. So just concluding, you want to make sure that all of your billing charges reflect accurately the services being rendered and the appropriateness. I think too many times ultrasounds are done every single visit just because it's fun, it's a nice boutique service, but it's one thing to do it just because you feel like it versus you're planning on billing an insurance company. So you have to think of the medical necessities, you have to think of your documentation, you have to think about the payer mixes. Are there limits? Are there exclusions? Are there steps you have to do before you can get that covered? And that's part of that decision making of, are you just going to give the care and take the risk, or are you going to spend a little time learning those hoops and those steps to get? So the medical necessity is a challenge. Typically, it's up to the clinician to determine the medical necessity, but there may be some prior auths, there may be some timelines. With point-of-care ultrasound, a lot of times we need these answers fast. So you are most of the time going to be doing it and hoping you get paid after the fact based on the evaluation that the insurance company determines if it was medically necessary. It's easier in OB triage when people are coming in for more urgent nature to get insurance to cover things versus like the clinic setting, and you could send them out to the sonographer in a couple days versus you did it at the bedside. You want to just make sure that the more urgent you need the information, the easier it is to defend as medical necessity, like ectopic pregnancy, vaginal bleeding, pelvic pain, estimating gestational age. Are there one baby, two babies? Is there cardiac activity? Are there any genetic abnormalities, high risk situations, pelvic masses, history of fibroids? Here are some of the common things for first trimester ultrasounds of why they're being done and billed to insurance company. You want to confirm that there is a viable pregnancy. You've got a positive urine pregnancy test, positive HCD in the clinic with blood. You want to rule out ectopic pregnancy. They're having left lower quadrant pain. They're approximately 5 weeks gestation. You want to confirm, is the pregnancy in the uterus? Is it in the fallopian tubes? Why are they having the pelvic plane? Is there a subchorionic hematoma involved that's causing some of the bleeding? You can't get a heartbeat, and you would expect to with a bedside Doppler, so you want to grab the ultrasound for peace of mind, anxiety, and give further information if the baby is viable, to assess severe significant fetal anomalies based on patients that are high risk. You can use it in conjunction with your genetic testing and just further evaluation of questions and some of the more common ones for second and third trimester. Typically, ACOG recommends a fetal anatomy scan between 18 to 20 weeks. If you do it a little bit closer to 22 to 24, you can visualize a lot of the anatomy a little bit better. And it's traditionally done by a physician, radiologist, sonographer. Advanced practice clinicians will do the limited point of care ultrasounds and bill those. Medical indications for performing these different things in the second and third trimester can be for ruling out concerns, problems. You can't tell baby's position with Leopold's, and so she's in early labor, you want to confirm baby's not breech. Is there one baby? Is there two babies? She has a history of preterm labor. You want to keep a close eye on her cervical length, her dates of her last menstrual period versus your fundal height are discrepancy, and so you want to do some growth ultrasounds and keep an eye on the baby. There are some anatomical issues found with the kidneys, the heart, whatnot on the anatomy scan, and you want to follow up on those things. You're not getting a heartbeat, and you'd expect to be getting a heartbeat. You want to confirm that suspected fetal death. You want to look at the overall well-being. You want to be able to assist with a cephalic version in be able to successfully turn the baby and make sure the baby's being safe. You want to rule out premature rupture of membranes and get a fluid level, check on placenta function, location. There's just so many things that it's usually not too hard for medical indication for these listed things. There's things for gynecological ultrasound procedures. You want to be able to look at the scope, the services, the indications, the specialty. Are you an infertility clinic? Do you do postmenopausal, hormonal? Is she having post-bleeding after she's postmenopausal? And you want to get an endometrial thickness. There's gross anomalies. She has a history of fibroids. What is the reason? What's the indication? Pelvic pain. The IUD placement. She can't feel the string. You want to be able to rule out multiple things. So these are the more common codes and sample charges that we've seen for gynecological ultrasound reimbursements across the country. 76830, just a generic ultrasound transvaginal. 76831, hysteronography with or without Doppler flow. 76856, ultrasound pelvic non-obstetrical real-time imaging. 76857, a limited focus. Want to look just at the follicles, just look at the IUD placement, not doing everything. And you can make a decision with your organization if you should do a thorough pelvic ultrasound every time you grab the machine or just to focus one. All I can say is every organization is going to have different scopes and services and billing guidelines and rules based on their payers and who they're serving and how they're serving them. You just need to familiarize yourself with the CPT codes, the services, hey, this is something I need to clarify with my biller. How do I have to document? What do I need to charge? What steps do I need to do so that we can get this paid and covered? Because revenue is really important to practices to make sure if you're providing skills and services and that ultrasound machine has an upkeep to it, understand what is medically necessary and what isn't, making sure you're using the correct CPT codes, place of service, providers, scope of practice, modifiers, looking at the payers' policies and keeping update with it. Some of it's going to be your billing department, some of it's going to be direct education and training, what certifications, what guidelines, what requirements based on your organization, based on the state, based on national guidelines, based on payer mixes. You need to be really familiar with how you and your specific services can be rendered and be billed to insurance companies. You need to look at, are you paper charting? Is your ultrasound machine integrated to your EHR system? Are there scripts? Are there flags? Are there little billing cues that are going to help you with being accurate when you're billing for procedures and those your point of care ultrasounds. It's really, really important to master billing and coding when you're dealing with the insurance companies. If you're providing a service, you should be getting paid for providing that service. So throughout this presentation, we've really went over the high level, low level aspects of more common ultrasound procedure charges, CPT codes, things to consider when you're billing limited point of care ultrasound.